off with some of the questions that I was going to get answers from our lab on Wednesday. So the guidelines, the algorithms that I give to you, basically is a summarization of like 200 pages of information. So, but then, those guidelines were released in 2022. Stuff has happened since 2022, right? So periodically they're going to release updated guidelines or consensus statements. And actually there was one, if you look here, in April of 24. So this year, the American College of Cardiology released in their journal this consensus statement regarding treatment pathway for heart failure with reduced ejection fraction. And as you're reading this 100-page document, there's a table in there which is kind of nice as far as indications for the use of ARNI. So we had a question, why are ARNIs recommended in treatment for NYHA class 2s and 3s, but not 4s? Well, in the consensus statement, they actually are recommended now. It's being used in class 4, so severe heart failure symptoms. So go ahead and treat it with that. If you read also in it, there was the question of, well, they're already on an ACE. Am I going to stop the ACE and put them on an ARNI? The answer is yes. Because of the additional benefits that the neprilysin inhibitor provides for preventing the remodeling and everything that could further deteriorate the function of the heart, they actually do recommend stopping an ACE, stopping an ARB, and putting on the patient on the ARNI, because then you get that extra neprilysin inhibitor effect and those benefits associated with it. Now there are recommendations on how do you stop the ACE, or how do you stop the ACE before you start them on the ARNI. I'm not going to test you to that. That's going to be like a phase 2 type of scenario that you're going to have to investigate and figure out, and why it is bad for you to immediately go from an ACE inhibitor to a ARNI. So, but we're not going to be tested on that, so I'm not going to delve into that and complicate things. The other question we had was SGLT2 inhibitors. So when I looked into it, actually in heart failure, it is recommended in patients who have and don't have diabetes. So this is actually something that you can go ahead and put them on even if they don't have diabetes. So I was incorrect when I was telling you that. So this is maybe along the lines of like the GLP-1 inhibitors, where even folks who don't have diabetes benefit from the use of the SGLT2 inhibitors. So, so in any patient who meets the criteria for SGLT2 inhibitors, like the stage C, go ahead and start them, and make sure they're on that as part of their goal-directed medical therapy. So, questions about that? Okay. So let's get started. So, valvular heart diseases. So a lot of your test, so 16-ish questions of your test are going to be based off of valvular heart diseases, because we get 2 lectures of our 6 just based on this, which includes the rheumatic heart disease material as well. So expect about 16 questions on the valvular heart disease 1 and 2 lectures. And a lot of it is going to be just identifying the murmur and what that valvular lesion is, and potentially what the treatments are for those things. So definitely focus on being able to identify a murmur. I will always give you, if it's systolic or diastolic, I will always give you the pattern, whether it's crescendo, decrescendo, or decrescendo by itself, or the other kind of configurations that you get. So I always will give you that to you. I will always give you where you're hearing it. Now, it may not be the mitral auscultation point. It's going to be more likely the right upper sternal border, left upper sternal border, left sternal border, left lower sternal border, and apex. So know those terms so you can identify the murmur based on those locations. So now I may throw in some extra detail like rumbling or those type of things, but those are kind of distractor terms that don't let that kind of trip you up. But I will definitely give you systolic, diastolic. I'll definitely give you the configuration of the sound and where you're hearing it. And that should be sufficient for you to identify the valvular lesion. So we talked about regurg. Remember, regurg is basically the valves are not sealing closed when they should. So you're getting a backflow of blood through that poorly sealed valvular area. So regurgitation murmurs occur when that valve should be closed. Stenosis is a resistance to opening. So you're going to hear this murmur when that valve should be open. So if it is a systolic murmur and you're thinking it's stenosis, well, you should be thinking it is a pulmonic or an aortic stenosis, right? If it is a systolic murmur, but I'm talking about, in the tricuspid mitral area, then you should be thinking it is a regurgitation murmur. And if you like acronyms, here's your murmurs that you're going to hear during systole. There's also the chart on basically what murmurs are present in systole and diastole, or continuous in a couple of cases, based on the auscultation sites. And then you had your diastolic murmur acronym, just to kind of help you remember what's going to be diastolic and where you're going to hear those. Not all murmurs are pathologic. There are some that typically you may hear but don't require a workup. But the biggest things to kind of remember are if they are diastolic or pansystolic, or holosystolic is another term for pansystolic, then those require workups. If it's late or loud, then that requires a workup. So basically, if you should be thinking of a benign murmur, it's potentially going to be a systolic, soft murmur. But everything else is pathologic, needs an evaluation done. Then we talked about rheumatic heart disease, rheumatic fever, and we talked about how this is a progressive disease related to a strep infection, particularly a strep tonsillitis or strep pharyngitis infection that involves group A strep. Typically think of folks who are going to be at risk of developing this condition or this syndrome are folks who have this and remain untreated. So they don't get antibiotics to eliminate and get the strep A bacteria. If they don't get treatment, then about 2 to 3 weeks, potentially 2 to 3 weeks later, they are going to develop acute rheumatic fever, which is going to be your Jones criteria, which we'll go into depth about Jones criteria here in a little bit. And then if they develop acute rheumatic fever, then they are at a much higher risk in 10 to 30 years to develop rheumatic heart disease. Now, the difference is the valvular disorders that you have in rheumatic fever are just temporary things, whereas in rheumatic heart disease, this is permanent damage that's already done to the valves themselves. You can't get rheumatic heart disease if you have never had this. So you always have to have that strep tonsillitis before you can even develop the other two conditions. Rheumatic fever itself, biggest thing, it gets cut off in the bottom. So biggest thing, treat strep throat, treat strep throat, treat strep throat. Your penicillin antibiotics are your best ones, but there are alternatives that are suitable to eliminate group A strep bacteria. But the biggest thing is that they are on an antibiotic that will kill that bacteria. Because without treatment, 3% of those folks are going to go and develop acute rheumatic fever. And when they do develop acute rheumatic fever, they're going to have that Jones criteria. I'm sorry, let me go back. So, which has major criteria and minor criteria. Remember, minor criteria are very non-specific kind of things, and a lot of different infections you may have these. although I would say this prolonged PR interval and EKG may be a little more unique to this compared to just a regular infection. But remember, there are the minor criterias. And then the major criteria, we're going to go into more in depth on those. But again, have to have evidence of a streptococcal infection preceding the rheumatic fever. So as far as major criteria, the Jones criteria, J is for joints. So you get this polyarthritis. It's the most common symptom that you're going to see in your patients with rheumatic fever. They'll expect to have this inflammation, these joint aches in the major joints. The O, if you change the O to look like a heart, it's carditis. So the heart involvement, which is the second most common symptom or cluster of symptoms that you're going to have in somebody with rheumatic fever. And it can affect multiple valves in the heart, and they can develop this stenotic or a regurgitation murmur. So it's not just stenosis and it's not just regurgitation. They may develop both kinds of murmurs associated with it. So a new onset heart murmur in the setting of like joint aches, kind of be thinking rheumatic fever. And then there's some other symptoms that they can get related to the heart itself, including impaired ventricular contractility, which could lead to heart failure-like symptoms. The N is nodules. So these are rare. This is the least common symptom that you're going to get, but these are subcutaneous nodules that they'll have, and they tend to be painless. E is the erythema marginatum rash that they'll get. It's non-pruritic and non-painful. And these are a little more common than the nodules, but typically if you're going to have nodules, you're going to have this symptom as well that kind of goes along with it. But it almost looks like a fungal rash where you have that central clearing. The difference is that non-pruritic component to it. And then the Sydenham's chorea, so 20% of patients will get this. So this is the third most likely symptom that you're going to get with acute rheumatic fever. And just remember that it's this involuntary rhythmic movements or tics, those types of things, where all of a sudden it comes on and then a couple weeks later it goes away. And then as far as being able to prove that there was a strep infection, there's a number of tests that you could do. So you could be able to get a rapid strep test or a throat culture test that's positive for group A strep. But if it is far enough out, these may not be positive. But so you do have some antibody testing that you could do that would show at least a history of a strep infection. So combination of what we routinely will use to test folks in the acute setting for strep throat, but also antibody testing to look for previous infections. How do we treat it? Well, let's give them antibiotics to get rid of any bacteria that still is present in the body. Let's get rid of it, and then they're going to be on high-dose aspirin for a period of time. And then patients who do experience acute rheumatic fever, they are going to be at a higher risk of recurrence of it if they were to get another strep infection. So they're going to be needing to be on some kind of group A strep prophylactic antibiotic regimen for a period of time. Folks who then have acute rheumatic fever are at a much higher risk of developing rheumatic heart disease, not acute rheumatic heart disease, but rheumatic heart disease. And typically these symptoms will come on about 10 to 30 years after they've had that rheumatic fever. And this will cause a permanent impairment of valves in the heart. Mitral valve is the most common one, but the aortic valve is the second most common, and then tricuspid valve is the third most common valve affected from this. And the valvular damage that does occur can be either a stenotic or a regurgitation, and the consequences of having those diseases will lead to further complications related to this. Question about rheumatic heart diseases. Okay. So we'll talk about mitral stenosis. So remember, mitral valve is supposed to be opening during diastole to allow blood flowing from the left atria into the left ventricle. When it is resistant to opening, you get an increase in pressure, which then will back up into the left atria, increase the pressure there, which will then back up into the lungs and cause increased pressures in the lungs, which again can lead to pulmonary edema and congestion there, leading to pulmonary symptoms. This is going to get worse if somebody has AFib, where you lose that atrial kick and you lose that ability to kind of provide that extra pressure in order to increase the amount of blood volume leaving the atria and going into the ventricle. Remember, the ventricle in this situation works normally, so whatever blood does get there, it's going to squeeze it out. The problem in this situation is getting the blood to the ventricle to be able to support that cardiac output. And when you have it, you're going to have this decrescendo crescendo diastolic murmur. And it's going to be best heard in the the apex. I'm trying to look on the slide. I don't see. Oh yeah, here, apex. Best heard at the apex. So your EKG, because of that extra pressure building up in the atria, you're going to get that left atrial enlargement. So you may get this P mitrale, which is that kind of that double notching of the P wave on your EKG. And then chest x-ray, so additional ancillary studies, you may start to see the evidence of pulmonary congestion, including like your curly B lines and such. Echoes, test of choice basically for every condition that we talked about in this block. But you're going to get this fish mouth appearance on echo. And the reason this is kind of classic for mitral stenosis, the fish mouth, is remember the mitral valve is only 2 leaflets as opposed to all the other leaflets, which are 3. So that's why you get the kind of this fish mouth appearance. Now the only other time you may have a fish mouth appearance is if you have a congenital bicuspid aortic valve where you get stenosis of that, but that's a completely different condition. But normally, in a normal mitral valve, it's just the 2 leaflets, and you'll get this fish mouth appearance. How do you treat it? Well, let's manage the excessive preload. So let's do salt restriction. We'll do diuretics. Let's do beta blockers to increase our diastolic filling time, right? We're going to slow down that heart rate, increase that diastolic filling time, because remember, the contractility of the ventricle is normal. So just giving them beta blockers and decreasing the contractility a little bit is not going to have that significant of impact on the ventricle itself. And then if they have arrhythmias, then you're going to be needing to do some additional treatments managing the arrhythmia, but then also the anticoagulants associated with that. For severe symptomatic disease, the preferred treatment for us is actually doing this percutaneous mitral balloon valvotomy. Basically, they thread the balloon in through the mitral valve, inflate it, and it pops open the valve and gets rid of some of the stenosis features of it, so it can open and close more normally. But if that's not a good option, it's advanced disease or whatever, then they can get a mitral valve replacement entirely, which any kind of valvular replacements is either going to be this biologic or a mechanical valve. Remember, there are advantages for both. For biologic, the great thing is it doesn't require anticoagulation. So You don't need to do this. Unfortunately, though, it has a short lifespan. So either these are going to be placed in folks who cannot be on anticoagulation because of other things, or typically somebody who is older, who doesn't really have much of a lifespan, life expectancy left. We're going to put this in there because they most likely will die before they need a replacement. Mechanical valve has a much longer lifespan, so typically think of it like your younger people who have a much longer life expectancy, but they have to be able to tolerate anticoagulation because they're going to have to be on this lifelong. Mitral regurg. So recall and basically just think of any condition that is regurgitation. There are primary and there are secondary causes, and there are acute and chronic pathophysiology consequences related to the regurg. So primary, be thinking that there is something inherently wrong with the valve itself, whereas secondary is there's something outside of the valve leaflets that is causing the regurgitation. So think of it as like somebody who has a dilation of the ventricle. It pulls those leaflets apart, and now they don't seal closed like they should, and you get that regurgitation. For acute mitral regurg, the body hasn't been able to develop the compensatory mechanism to handle that extra volume, so it tends to cause significant consequences pretty quickly. So be thinking of acute mitral regurg is going to lead to a pulmonary congestion pretty quickly. But think of things like rupture of papillary muscles, chordaes, those things where you get that acute regurgitation. With chronic, be thinking of like congenital or rheumatic deformities of it, where something that just takes time for that process to develop. As far as pathophys for acute end is this pulmonary congestion and edema, as well as now you have reduced cardiac output because of that volume is going up to the atria as opposed to going out through the aortic valve. In chronic, be thinking more along the lines of the cardiac output reduction, and then also you're going to have some dilation of the atria, so you can accept additional volume there without increasing the pressure. So it's going to ultimately lead to a pulmonary edema, but it's going to be a much slower process for it. So the predominant symptom in this is going to be your cardiac output symptoms. And what are you going to see or hear? So it's a holosystolic murmur, best heard at the apex, so the mitral auscultation site. And then if you do anything to increase the afterload, you're going to see that this gets worse. Because now there's more resistance to open up that aortic valve, so it's going to want to regurgitate to the atria instead of going out through the aortic valve. EKG, what can you see? So left atrial enlargement again, so you might get that P mitrale. Chest x-ray, you're going to see enlargement of the left atria especially, but you might see some ventricular dilation, and then just overall cardiomegaly because of the heart being bigger because those chambers are bigger. How do you treat it? Well, acute, remember the body doesn't have the compensatory mechanism in place, so you're going to be doing things to decrease the afterload quickly, because you're trying to encourage that volume or more volume to actually go through the aortic valve and out systemically, then regurgitate up into the atria, because the atria is not able to handle that extra volume without it backing up into the lungs quickly. So doing things like nitroprusside would be the treatment for that. You want to avoid meds to slow the heart rate down because you don't want to accumulate more volume necessarily to regurgitate. So you don't want to do things like beta blockers, calcium channel blockers. For chronic though, for primary causes, you're just going to replace the valve. So things that are inherently wrong with the valve itself, you're going to just replace the valve. But for secondary causes, you're going to want to do things to manage the symptoms, the complications. You can determine what exactly is causing that condition, treat those things. So if it's like heart failure causing a dilation of the ventricle, then use the typical things that we would do in heart failure. Mitral valve prolapse. This is there's like kind of two components, or potentially two components to this. So there's just that billowing of the valve, the mitral valve, into the atria. That may still remain closed, so you still may have that integrity of the valve. It's just kind of billowing excessively into the atria. But sometimes if it is bad enough, it will open the valve and you'll get this regurgitation. So it's possible that you have mitral valve prolapse and you're going to hear like the click of the prolapse, but you may not hear the regurgitation component to it, or you may hear both if regurgitation is present. Primary causes of it, so there are the connective tissue disorders. There may be some familial inheritance for this as well. Vast majority of patients who have mitral valve prolapse are asymptomatic, especially if it still has that integrity of the valve where it just billows excessively without opening. But if it does start to have problems, be thinking things like the regurgitation of the blood is present, and it's going to cause those symptoms that we discussed under mitral regurg. And then we talked about how dynamic maneuvers. So by standing or valsalvating, I'm going to advance the click, so I'm going to make the click sooner and lengthen the murmur. If I do squatting or leg raises and I increase my venous return, this is going to delay the click. So just knowing kind of what's going to happen is I'm going to describe a mitral valve prolapse murmur, and I'm going to say, Valsalva did this to it. What's the most likely heart murmur, heart valvular disorder, or whatever. So EKG may be normal. It may, if there is the mitral regurg, may show the same things that you find with mitral regurg. Chest X-ray itself, you may see some things on it if there is that mitral regurg, but if it is just the valve prolapsing, it's going to look normal. Echo is going to actually show you the prolapse, and then it'll also show you if it opens up and there is a regurgitation component to it. How do you treat it? Well, really, reassurance in a lot of ways, but if they are having problems, especially the severe regurgitation, then you're going to treat it like a mitral regurg condition. Questions on the mitral valve? So the aortic valve, so aortic stenosis is the most common cardiac lesion in the US, developed countries in general. Most commonly, congenital bicuspid valve is there, but you also do have degeneration. So think of your patients who have atherosclerotic diseases or those risk factors. They are going to be at risk for developing this condition. And then globally, rheumatic heart valve or heart disease is a concern. A lot of times there's a asymptomatic period that tends to be very prolonged, but when they do start to have symptoms, be thinking of things that are due to reduced cardiac output. So because of the stenosis, that resistance to open, you're going to not get as much of a cardiac output to it. So dyspnea on exertion, exertional angina, so symptoms with exertion. And again, the exertional dizziness and syncope. And then ultimately, if it's bad enough, that extra pressure is going to affect the ventricle. It's going to back up into the atria, and then it's going to back up into the lungs, and you're going to get the heart failure symptoms. What are you going to hear? So you're going to have this crescendo decrescendo pattern. best heard in the right upper sternal border, so in the aortic auscultation site. It tends to radiate to the carotids because that turbulent blood flow is going towards the carotids, or basically up to the aortic arch, and so you're going to hear this radiate up to the carotids. EKG, you're going to have this LVH present because of that extra pressure. The heart's going to compensate for it to try to get a more effective, a stronger squeeze. So you're going to see that LVH on EKG. Chest X-ray, yeah, you may see some complications related to the condition itself, but echo is going to be your test of choice because you're going to be able to see how bad the stenosis is, measure different values to help you determine treatment for it. And recall that in aortic stenosis exercise testing, if you have a patient who says they're not having any symptoms and they meet the definition on echo as having severe aortic stenosis, then they do warrant exercise testing to see if they actually truly are asymptomatic because of this. And the reason for it is if they are actually having symptoms, but they just adjusted their lifestyle to be less because of the symptoms, their mortality rate drastically increases. So, not expecting you to memorize the definition according to this table, but just realize a valvular area of less than 1 centimeter is by definition severe aortic stenosis. How do you treat it? Well, maybe manage hypertension, so decrease that afterload would be good, especially with ACE inhibitors because it can help with reducing the remodeling that happens as part of this disease, or the heart's trying to compensate for this disease. But ultimately, these folks are going to be going and getting a TAVR, so the trans-aortic valve replacement. So they're just going to go in, replace the valve, and then fix the stenosis. If they start having problem or start having additional symptoms, so if they have angina, they have less than 5-year life expectancy, syncope is less than 3, if they have dyspnea, less than 2 years to survive or to live. So they may benefit by getting an aortic valve replacement done sooner rather than later. Aortic regurgitation, again, remember acute versus chronic, remember primary versus secondary causes of this, the pathophysiology is going to be different with the acute versus chronic. In somebody who is chronic aortic regurg, the heart has had the time to develop compensatory changes for this. And one of them is going to be basically, they're going to have a higher systolic blood pressure, but a lower diastolic blood pressure, which is ultimately going to lead to a widened pulse pressure. So you get a more effective, stronger squeeze, which increases the systolic blood pressure, but because that valve integrity is not there, and now you get that regurgitation of blood down into the ventricle, that diastolic blood pressure is going to drop. So that's why you get that disparity between the systolic and the diastolic pressures. Acute aortic regurg, okay, be thinking we did something to it, or there's trauma. But the pathophysiology for this is you're going to have increased pressure and volume, and that's going to then go up to the atria, which is then going to go to the pulmonary system, the lungs, because the body or the heart hasn't had the opportunity to compensate by making the left ventricle bigger or the left atria bigger to accept that extra volume. So pressure becomes an issue pretty early on. And then we talked about this. Recall that in aortic regurg, there's all these different kind of things. So head bobbing or pulsations of the uvula, the Warhammer sign. So there's other physical exam findings with aortic regurgitation that you'll see just by observing your patient. What are you going to hear? So it's a diastolic murmur, best heard at Erb's point, so the left sternal space, and it tends to be kind of this decrescendo pattern that you see kind of up here. There may be an additional murmur associated with this, where because of the regurgitation of blood down from the aorta into the ventricle, it's going to hit that anterior leaflet of the mitral valve and push it back, push it closed. So now you actually hear somewhat of like a stenotic, mitral stenotic kind of murmur, because that blood coming from the atria is hitting that valve leaflet that shouldn't be there normally. And that's called this Austin Flint murmur. EKG, especially in chronic, you're going to see this left ventricular, left atrial enlargement. Chest x-ray, you're going to potentially see the pulmonary congestion, especially in acute. Chronic, you're going to see cardiomegaly related to that. Echo is going to be a test of choice. You can measure the degree of regurgitation that is present. And then you're going to be able to evaluate for the secondary consequences because of the regurgitation. How do you treat it? Well, ultimately, probably surgery if it's severe enough, but if they don't warrant surgery, then you can put them on the ACE inhibitors or the calcium channel blockers to decrease that afterload so you don't have this elevated systolic blood pressures. And then surgery, if it's severe symptomatic or their heart function is deteriorating because of this, then those are indications for them to get surgery done. And then this is a progressive disorder, so without surgery, especially if they start developing symptoms, that life expectancy starts to drop. So, any questions about that? Tricuspid stenosis, so a decrescendo crescendo, left lower sternal border, so the tricuspid auscultation site, and it's a diastolic murmur. EKG, because it's going to increase the pressure in the right atria, you're going to see right atrial enlargement associated with that. Chest x-ray may see the same finding, but your echo is going to be your test of choice. How do you treat it? Well, let's reduce the volume coming back to the heart. So let's do diuretics and do salt restriction. And then typically surgery is what's necessary if it's for severe disease. And it could be that they just do the balloon valvotomy like we talked about for the mitral valve, or they can just go in and replace the valve entirely. Tricuspid regurg, again, secondary causes and primary causes associated with that. The pathophysiology is different if it is acute versus chronic. For acute, you're going to have right atrial dilation, and it's going to lead to right heart failure pretty quickly. If it is chronic, yeah, sure, the right atria is going to dilate, but you're going to have the addition of the right ventricular hypertrophy because the heart has had the opportunity to hypertrophy the right ventricle, and then that ultimately will lead to right heart failure. But your body has tried to compensate for this in that condition in the chronic setting. So what are you going to see? Well, symptoms of right-sided heart failure. And then if we were comparing it to JVP, because this is now the right side of the heart, they're going to have prominent V waves present on JVP pulsation waves. What are you going to hear? Well, a holosystolic murmur, best heard in the left lower sternal border, so the tricuspid auscultation site. Is going to be kind of what the main things you're going to hear. EKG, okay, right atrial, right ventricular enlargement, same thing with chest x-ray. Echo is going to actually show the regurgitation, and you can measure how severe the regurgitation is, and also measure the secondary consequences of having this condition. How do you treat it? Well, if we're not going to do surgery, so treat the underlying cause if it's secondary causes. If it's primary, you're going to do diuretics just to reduce that excess volume, reduce that preload or the venous return coming back to the heart. But ultimately, surgery tends to be one of the best ways to treat it if it's severe enough. And then the last heart valve with pulmonic stenosis tends to be congenital, and most commonly there are, we talked about tetralogy of Fallot during the first block, but this Noonan syndrome, it's one of the criteria for Noonan syndrome, which is a genetically inherited disorder. What happens with this, it's a stenosis, so it's going to be a pressure problem. You're going to have increased RV pressure. That's then going to lead to right heart failure, because it's going to back up from the ventricle into the atria and then to the systemic venous system. They tend to be asymptomatic initially, but it's going to progressively deteriorate. You're going to hear a crescendo-decrescendo pattern, systolic in the pulmonic auscultation site, so the left upper sternal border. And then EKG is going to show the right ventricular hypertrophy. TTE is going to show you the stenosis and the secondary effects of it. How do you treat it? Well, let's do a balloon valvuloplasty if possible. And then the last condition is pulmonic regurg. So with regurgitation, you're going to get increased right ventricular volume. It's going to lead to right ventricular dilation, which is going to lead to right heart failure symptoms. And then we talked about those types of symptoms with right-sided heart failure. And what you're going to hear is going to be this decrescendo diastolic murmur, best heard at Erb's point. And then echo, of course, is going to be a test of choice. Treatment, if they're asymptomatic, just observe them. But if it's bad enough, especially if they're having like pulmonary artery hypertension, treat those symptoms. But in severe cases, they may need a valve replacement. Questions about valvular heart disease? Okay. Got 7 minutes before we're at the 50-minute mark, so let me try getting through this as much as I can before we get a break. So, heart failure, the pathophysiology, remember we talked about cardiac output and the components that go along with it. So you have the contractility, preload and afterload components that affect stroke volume. Remember, contractility and preload have a positive effect on stroke volume, but afterload tends to have a negative effect on stroke volume. So, and ultimately the stroke volume plus multiplied by your heart rate equals your cardiac output. So usually with heart failure and the conditions that cause it, there's some variation that causes those things to change, those variables to change, which will lead to decreased cardiac output. There are systolic heart failures. There are different ways we classify heart failures. There's systolic, which is your HFrEF, your reduced ejection fraction. There is diastolic, which is your HFpEF, the preserved ejection fraction. There's left-sided and right-sided heart failure. Left side impacts the lungs directly. The right side affects the systemic venous system. Low output is what we traditionally think of as far as heart failure goes. But there is the high output where basically the heart is beating too fast or is working too fast or hard, and it leads to wearing the heart out. So systolic dysfunction is 2/3 of your cases, so the HFrEF, the reduced ejection fraction, which be thinking things that are as a consequence of coronary artery disease and the impacts of ischemia or infarcts. where the muscles themselves lose function. Ultimately, you're going to have decreased ejection fraction because you're losing that contractility, which is going to result in your stroke volume decreasing, which is going to ultimately lead to a decreased cardiac output. So what's going to happen then with this is because you're not squeezing the volume of blood that's in the left ventricle out, that volume is going to increase pressure. Pressure and volume then goes up to the left atria, which is then going to affect the lungs. And then you're going to get the symptoms of the lungs being impacted, but also because your cardiac output is being impacted, you're going to get the like the exertional kind of symptoms. Diastolic dysfunction is only about a third of your heart failure cases. This is your HFpEF. Be thinking of things that enlarge or hypertrophy the ventricle wall itself. So like LVH from poorly controlled high blood pressure, LVH from aortic stenosis, your hypertrophic cardiomyopathies, restricted cardiomyopathies, and then other things outside of the heart that just keep the heart from filling properly. With the pathophysiology of this, because you have a non-compliant ventricle, that pressure in the ventricle is going to increase pretty rapidly, especially with low volumes. So that pressure is going to then go up to the atria, which is then going to affect the lungs, and you're going to get the pulmonary symptoms associated with that. Left-sided heart failure, again, coronary artery disease is the most common cause for it. Right-sided, most common cause is the left side is giving you problems, so it's just the left side then starts affecting the right side's function. But there are other things that affect the right side. Like if you have a right-sided heart attack, that can cause that. Or if there is a pulmonary embolism or pulmonary hypertension, that will lead to right-sided heart failure. And then we talked about that. Low output, we pretty much talked about when basically it's just a low cardiac output, but the high output failure, so the cardiac output is there, but it's just excessive. It's working too hard and it just wears out the heart, and then that leads to failure. You have multiple compensatory mechanisms in place to help adjust for the failing heart, or the heart's not meeting its cardiac output requirements. Frank-Starling mechanism is an acute process, so this is something that can happen pretty rapidly to improve the function of the heart, but it can only go so far before it actually stops working correctly. Another acute compensatory mechanism that's there is sympathetic stimulation, where the sympathetic nervous system can either increase the contractility of the heart, or it can increase the rate of the heart to improve that cardiac output. Other compensatory mechanisms involve like baroreceptors that are kind of throughout the body that recognize that the pressures or the output's not there that needs to be there. So you start to get stimulation of other systems outside of the heart to try to affect the function of the heart. But remember, a lot of these are overall deleterious to the heart function itself, because it either increases the afterload, which is going to decrease your stroke volume, or it starts to decrease, or it starts to increase a preload, which in excessive amounts actually causes the heart to function worse. So things like your RAS or your antidiuretic hormone release can cause potentiate a heart failure. Endothelin 1 is released by the endothelium of the blood vessels themselves, which results in a vasoconstrictor. But basically, we're increasing our afterload with this, and so that is going to negatively impact the cardiac output. Your natriuretic peptides actually have a positive benefit. This is really your only thing that does have a positive benefit. By basically downregulating the RAS system, as well as vasopressin. So it recognizes that that's not what it needs in order to function normally or try to restore function. So these get released and it will help restore function. And that is 50 minutes, so let's take a break really quick and then we'll come back at 2 and finish up.